Dr. J. Lemery here from University of Colorado. I am the chief of the section of Wilderness and Environmental Medicine, and I just kind of wanted to give a little overview of what we've just been through and then talk about education. But I wanted to give you my journey, a quick, brief journey, because I think it sort of helps illustrate the perspective that we bring to the table. I got started in wilderness medicine right when I got out of residency. I really enjoyed the educational aspects of it. And of course, it's the art and science of taking care of people in remote and extreme places. I was at Weill Cornell New York Presbyterian for 8 years. You can see here, this is all, incredible wellness, and incredible ability to teach in this great classroom. Came out to Colorado because if you remember Cornell's med schools in Manhattan, we had kids, and kids in Manhattan don't mix. So it was time to move. We went to, came out to CU and started our program there. And while we were there, we got to get into some contract work in wilderness medicine. We supported the U.S. Antarctic program. We were the EMS medical directors, so that was cool, supporting the science and getting to know what the scientists were doing. Then recently we pivoted to the north and are now supporting the polar program for all the circumpolar researchers, all the people drilling ice cores and so forth. And we actually have the medic up here at some, it's like kryptonite. Don't push the green glowing button. Okay.
I think it'd be good to do that from the beginning. I can work on that.
Okay, so this is like a doomsday button. So anyway, so we were supporting the science. We got to know all the researchers there, and it just became one of those things where it was like, God, we're spending so much time thinking about these beautiful environments and going there, and all at the same time, this is about 10 years ago, that first spike of science being bashed became very troublesome, and there was a voice that kept calling, why the conspicuous absence? Thanks, Renee. Why the conspicuous absence, and where's the clinical community in this? Why aren't doctors weighing in when climate science is being tweaked and politicized? I was very struck by my mentor. Got cut off. It's the Physicians and the Environment by Paul Auerbach, former chair of emergency medicine at Stanford. And it was a 2-pager, very elegantly written, and it just sort of hit me at the right time. And I followed suit with my own smaller editorial in wilderness and environmental medicine, lessons from Dr. Strangelove, which I'm glad I see some older people here. You know who Strangelove is, right? We talk to the med students. They get kind of nervous. They're like, Strangelove. Do we have him in lab last year? Which guy was that? And of course, it was an essay comparing the existential, large, politicized, slow-moving crisis of nuclear proliferation with climate change, and say, look, we've been here before. There's a path for us to follow, an opportunity for medicine. When physicians from both sides of the Iron Curtain got together and said nuclear war is the final epidemic with no meaningful cure, and because of that, they won the Nobel Peace Prize. And I think, I make that comparison. I think we're at another historic opportunity for clinical health, for medicine to jump into the breach and reframe this whole issue. At CU, we started the Consortium for Climate Change and Health, and that was a recognition a couple of years ago. It said, we in medicine can't do this alone, so let's hook up with our climate scientists at Boulder, CU Boulder and the national labs there, basic science, School of Public Health, and then even within medicine, nephrology, infectious disease, and emergency medicine. And basically to do this, right, to reframe this as a health issue and use that power of science communication as a lever. Remember this guy? I knew him from reruns. Some of you maybe from primetime. Marcus Welby, America's Doctor, right? He epitomizes that trust that the public still has towards medicine, right? We tell our patients, all day long we're abstracting clinical science at the bedside, or basic science at the bedside rather. So You need to take aspirin, right? It prevents the plumbing of your heart from blocking. That's why you got to take it. And what do our patients say to us when we say that? Okay, doc, right? And I think that that still is something, as Jonathan pointed out, we still hold the public trust. And that's a very unique influence that we have, because the truth is we got to get away from this, right? Altruistic, save the whales, love Mother Earth, or the abstract parts per million of carbon dioxide. Now, you've been primed. Maybe you know what this means now, but most people don't. They don't know why 400 is a big deal versus 410 or 300. What does that all mean? And, I like whales. I like Earth, but it's a few steps away from action. When we start talking about our parents' risk of chronic lung disease, our kids' risk of asthma, it really changes the conversation. And so this is really what we're all trying to do here. Change. Don't hit that same button. I'm not even going to push it. I don't know which one, but change the polar bear to the kid with the inhaler. When we think of the house of medicine, right? Again, I'm sort of reviewing what we've talked about. Who should lead this? Well, as Cece kind of pointed out, climate change is the disease of infections, changing vector-borne disease, a disease of respiratory distress, so maybe pulmonologists have a role. Food insecurity, maybe a maternal child health. Waterborne illness, bring in internal medicine. Heat stress, so sports, wilderness medicine, mental illness, psychiatry, right? Displacement in trauma, so trauma surgeons or orthopedic surgeons. But no one seems to really be in the right spot when we reconsider this. But think about just even in the U.S. what happened last year. We had Puerto Rico, Houston, California, huge, complex, very large-scale health stressors, for lack of a better characterization. When we think about what is all this, I reframe it as climate change is a disease of two things. Okay, it's a disease of vulnerability, it's a disease of disaster response. And when you frame it like that, once again, the indispensability of emergency medicine comes to the emerges, right? And this is why we're going to own this, whether we like it or not. My slides got a little confused here. I want to talk a little bit about what we're doing in the education sphere, because it's really emerging through academic emergency medicine. At CU, we have a School of Medicine course that's combined with Boulder, Atmospheric and Oceanic Sciences, a very cool collaboration. It started off as a wilderness medicine course for undergrads, and a little bit of a pre-med, come check out the emergency room, see what's going on, a little backstage pass to medicine. And because it was almost like we had no other outlet to talk about this stuff at the undergrad level, we started infusing it slowly. We gave Cece's lecture, and then we came in and added another lecture, and soon it became pulling in people from this consortium to talk. And finally, a professor at Atmospheric Sciences said, "Hey, this is great. Do you mind if can we start giving it credit?" Which, of course, is great, because we're in the School of Medicine. We can't give undergrad credit. So that's one of the things that we're doing. We have a sorry, some of my slides got warped, but I can tell you what I was hoping to say. We have a med school elective, right, happening in next summer. We already have, or next spring, we already have 25 students registered. This is tricky, right? We don't have, the med school curriculum is really jam-packed. So a lot of efforts are like, hey, let's get the deans to sign on. And maybe that, if you remember at the end of the Obama administration, a bunch of deans did sign on at the White House. The follow-through has been lackluster. So it really comes back to us on the front lines, or even the assistant professors of the world, to kind of try and squeeze it in. And so it's a team effort. You have to find people that can bring the curriculum, and also people that are going to do the legwork and show up and teach. We also have a collaboration with the School of Public Health, the Colorado School of Public Health, where we teach with them, both MDs and MPHs teaching. When we thought about what the curriculum would look like, we said, okay, so let's write the curriculum. And it's like, well, how we really should codify this in a textbook. So with our friend George Luber at the CDC, I was asked to be an editor of this book. And the reason I was asked to be an editor of this textbook was we were having beers. He's an old friend, and I said, George, it can't be just a public health book. We've got to have clinical vignettes with real visceral patient cases, so we can squeeze it into med schools. It's got to be applicable to med schools. And finally, I kept hammering him on this, and finally his eyes got blurry. He's like, do you just want to do this with me? And I was like, yes, that sounds great. But it wasn't enough, and we knew it wasn't enough because it's a textbook. And every once in a while, I'll have a young, eager med student that comes up to me. He's like, I read your textbook, and I know they're lying. Because no one can read this. It's a textbook. It's like 670 pages of just really dense material. So remember this guy Auerbach, I went back to him and said, hey, we have been talking about this for quite a while, and we wrote this book, Enviromedics. We made up the name. It's nonsensical, but it hopefully is one way of sort of a one word that kind of links, environmental change with human health. And we reframed the initial manuscript to focus on climate and health. And it's full of visceral vignettes or clinical vignettes. So a lot of it is, it was the hottest day of the year, and Sally ran out of her inhaler. And it used to be only 1 week in the South Bronx. It was like this, but now it's, half the summer. And anyone that practices emergency medicine may roll their eyes because they're all emergency medicine composite patients. But what we really wanted to do is provide something that, shook the layperson reading it and say, this is sickness. We know sickness. It's the same thing. And that was really, trying to hammer home that science communication. We were lucky enough to attract the attention of a Denver-based nonprofit, the Living Closer Foundation, who said, we want to help you. What can we do? And we brainstormed and came up with this idea of creating a GME fellowship in climate and health science policy. So I'm going to ask you guys, there's not many of you in the room, but please tell your young learners, your residents, because we want to make sure we have good applicants for this. But it's 12 months. It's based in EM, not necessarily because it has to, but that's, again, where we are, and that's where we're incubating this idea. We have friends at the CDC, the NIH, American Meteorological Association, where Cece is our inaugural fellow, and going around and basically we have the ability to send her, get her into the room where the conversations are happening and into the field where meaningful science is taking place. And basically to create a leader, an emerging physician leader in climate and health science. This comes from a paper that's under review, but it's basically what are the competencies? And I'm happy to share these slides with you, but just read the top bullet. Knowledge of scientific foundations, U.S. government and relevant state policies and institutions, same for international, global governance and climate change. Of course, a keen sense of the health implications of climate change, a little bit about health impact vulnerability assessment, and then, of course, being able to, which we've seen, kill it on the podium, be an effective communicator, know how to tweet. You're just joking. She actually doesn't have a Twitter account. But being an effective, competent, and confident communicator. I just put this here because these are the other groups that are friends with us working in the education sphere, and I think it's really important, and this is SAEM logo down here, but interfacing with these groups because the danger is, of course, redundancy and duplication, but you want to kind of have everyone talking. So Clean Med is Healthcare Without Harms Conference. We were just there last week. The Medical Society Consortium of Health is based at the George Mason Center for Climate Change Communication, and they're doing great work bringing the medical colleges together. Of note, we have internal medicine, ACP, family medicine, pediatrics, ACOG are all there. EM is not there, so we're super excited to be here because we feel like this is going to generate some momentum. And then the Columbia has a global consortium on climate and health education. They're trying to say, hey, what are the core competencies for education for different learners, whether it's pre-health, practicing a healthcare provider, and bringing that together. And then a nonprofit called Climate for Health, who do a lot with climate communication, and they've done very well with a document for care providers to talk about climate change and health, and it's very, very good. I didn't think I had anything to learn from them, but I read this document. I'm like, oh my God, I've been doing this all wrong, because they just give excellent, succinct bullet points on how to talk to different stakeholders in this arena. Alistair Woodward wrote he was the editor of the Intergovernmental Panel on Climate Change's health section, and he came to speak in Boulder, and he's a very soft-spoken man, very poised, and I think someone asked him, like, what are you most worried about now? And all the IPCC and the scientific predictions by convention go to 2100 the year. By 2100, sea level rise will be between here and here. Here's the range of mosquito-borne disease. And he said, the 2100 generation, this way off into the future business, like, they're alive today. People that are alive today will be alive then, And there was a palpable, shock in the room. And I think that's something that I think we have to remember, is that we're slowly, every step we move, and Stuart sort of said this elegantly, like, will we be that generation who we had all the data, and will we be remembered as the generation of the great procrastination or something else? And I think that this speaks to that. So in conclusion, I just wanted to say we put this piece in the BMJ. We need climate doctors. Not necessarily thinking that we actually need climate doctors, board-certified climatologists, but it just spoke to the fact that we all need to be moving towards a center place on this. We need leadership because it's super complicated, and no field really does own it. I think we've made the case today to say that EM is best suited to lead, but it doesn't cover all the bases. And in fact, probably medicine can't, because we're going to need to have really smart environmental scientists as well. But we made the case to say few clinicians have been educated and even less prepared and equipped to handle this. We're all learning. Healthcare providers are natural educators, science communicators. We're very comfortable translating abstract concepts into treatment plans. Like, we don't necessarily have to keep our mouths shut and let the data speak for itself because we're funded researchers. We're a little bit more loose because we have to be. We have to make instant decisions at the bedside with imprecise information. And so I think we can fulfill that communication role in a way that a funded scientist can't, because they really have to be cautious in what they say, whereas we, I think, can be a little bit more flexible. We have to train ourselves, cross-train in medicine, environmental science, and public health. Think with a multidisciplinary mindset, with novel skill sets, and as Stuart said at the beginning, a compelling narrative. Tell that story that's going to change hearts and minds. Because the truth is, if we don't do something, we're going to be putting ourselves more and more at risk. So I'll stop there, and I think we have a panel.